Good morning. Today I'll be presenting paper about evaluation of asymmetry in chain plug images between the two eyes of keratoconus patients. At outset, I would like to thank everyone involved in giving me this opportunity to present at this summit. Keratoconus is a bilateral corneal ectatic disease primarily characterized by progressive corneal protrusion and stromal thinning located in the inferior or inferior temporal area of the cornea. The shield plug principle is geometric rule used in photography that enhances the depth of the focus without distorting the image significantly. About 25 to 50 shield plug images are acquired during one scan for a 3D tomographic reconstruction of the pentacam. The pentacam rotating shield plug camera assesses the curvature and elevation of the anterior and posterior corneal surface as well as pachymetry with the high reproducibility and repeatability. Aims and objective is to evaluate the correlation between inter-eye asymmetry of pachymetric data and posterior elevation values of subjects with keratoconus and in those with normal corneas, and to assess the combined accuracy of pachymetric data and posterior elevation values in discriminating the normal corneas from those with keratoconus. It is a hospital-based observational cross-section study of 68 subjects with bilateral 3D shield plug corneal tomography using ocular pentacam imaging, 34 subjects with bilateral normal corneas and 34 with bilateral keratoconus. The outcome measured are keratometry at flat steep meridians, Kmax, central corneal thickness, pachymetry at the thinnest location, posterior elevation at the thinnest point of the cornea. The inter-eye asymmetry determined by subtracting the lower values from the higher values for each variable. The higher K1, K2 posterior elevation and lower central corneal thickness and thinnest corneal thickness are considered as worse eye. The area under receiver operator characteristic curve used to compare the predictive accuracy of different variables for keratoconus. The statistical analysis was done using SPSS version 17. The Mann-Whitney test used to compare the result between the keratoconic and normal subject, and unpaired t-test was used to compare the inter-eye asymmetry of keratoconus and normal subject. The cases were patients with bilateral keratoconus and controls were the patients with normal corneas. With no clinically significant keratoconus signs and symptoms and refractive error of less than 5 diopter sphere and astigmatism of less than 3 diopter with no previous ocular surgery or not with the irregular cornea. Coming to results, total of 68 subjects, that is 136 eyes were analyzed with pentacam, where 34 with bilateral normal eyes and 34 with bilateral keratoconus. The mean age of the keratoconus group was found to be 19 with plus or minus 5 years, and normal group was 23 plus or minus 6 years. Male to female ratio in both case and control was 18 and 16 respectively. This is a table demonstrating the mean inter-eye asymmetry along with standard deviation for normal group and keratoconus group. The difference between inter-eye asymmetry was statistically significant. This is table showing the better eye and worse eye, the mean of different parameter from the pentacam. In this table, we can see that in normal patients, there is no statistical significance between the better eye and the worse eye, whereas in keratoconus, there is a significant difference. The efficacy of inter-eye asymmetry values are depicted in this table. For example, the posterior elevation difference between the eye of 5.5 micrometer was found to have a sensitivity of 76% and specificity of 94%. to differentiate the normal eyes from the keratoconus eyes. The Laurent, coming to discussion, the Laurent et al. Conducted a case control study in 2016 on 97 patients in which 65 had bilateral cornea keratoconus and 65 were normal corneas and 32 keratoconus subjects. And parameter taken were CCT, TSCT, and posterior elevation using sheen plug imaging pentacam, and it was concluded that there is an increased inter-eye asymmetry in keratometry, pachymetry, and posterior elevation values in keratoconic patients compared to the subjects with normal corneas. A retrospective observational study was conducted by Jonathan D. et al. In 2014, where 177 healthy and 42 indeterminate and 121 patients with keratoconus concluded that the patients with keratoconus had significantly greater inter-eye asymmetry in all descriptors. Henriquez M.A. et al. Conducted a prospective study that included 151 patients with pentacam imaging in both eyes, 53 subjects with bilateral normal corneas and 98 with bilateral keratoconus, and concluded that there is inter-eye asymmetry in keratoconus patients than normal cornea. On concluding, there is a greater inter-eye asymmetry in pachymetry and posterior corneal elevation variables in keratoconic patients than in subjects with normal corneas. Our study suggests that the evaluation of the asymmetry in normal subject and keratoconus patients should not be done only with anterior surface data, should also include other parameters and inter-eye asymmetry concerning pachymetry data and posterior elevation data. Thank you.
Thank you, Dr. Kirti. Who is the next presenter?
Good morning, everyone. I'm Dr. Spurti Natraj. My paper is on simultaneous topography guided photorefractive keratectomy and collagen cross-linking in keratoconus. I have no financial disclosure. Keratoconus is a progressive bilateral asymmetric ectatic disease which causes progressive corneal thinning and protrusion of the cornea, leading to irregular astigmatism and visual deterioration. So generally we do corneal collagen cross-linking in such patients. Here the riboflavin plays the role of a photosensitizer in a photopolymerization process when combined with UVA radiation, which increases the formation of covalent bonds between the collagen fibrils. So the purpose of my study was to evaluate the visual and clinical outcomes of simultaneous topography guided photorefractive keratectomy and corneal collagen cross-linking in keratoconus. Coming to the materials and methods, when patients with keratoconus visited our OPD, we looked at the inclusion and exclusion criteria of our study. The inclusion criteria included patients above the age of 18 years, patients willing to give written informed consent, patients with mild to moderate keratoconus, and the expected corneal thickness after the stromal ablation following PRK was supposed to be about 350 microns. Such patients were included in our study, and the patients who were excluded from our study were who had any previous history of ocular surgeries, pregnant and lactating mothers, and any history of hypersensitivity to riboflavin. So in the end, we included 55 eyes of 55 patients in our study. So how do we go about the procedure? So this is the Atlas 9000 corneal topographer. So the corneal topography of the patient is done on this machine. Then the data is transferred to the Zeiss CRS master where the treatment planning takes place. Then the data is loaded onto the Zeiss MEL 90 excimer laser machine, where initially the patient's corneal epithelium is debrided using 20% alcohol. Then we do stromal ablation depending on the treatment algorithm generated. Following this, patient is immediately taken up for corneal collagen cross-linking, where depending on the residual stromal bed thickness, hypotonic or isotonic riboflavin solution is instilled for 30 minutes at the interval of every 2 minutes. And then patient is exposed to UVA radiation of 365 nanometers at 9 milliwatts per centimeter square for 10 minutes. following which BCL is applied and patient is advised post-operative drops. Coming to the results of our study, at 1 year, we found that the mean uncorrected visual acuity improved from 0.51 logmar to from 0.84 logmar, and the best corrected visual acuity improved to 0.23 logmar. The average K1 and K2 readings were reduced by 1.7 diopters and 2.18 diopters respectively, and the Kmax of these patients were found to be flattened by 4.27 diopters. All our findings were found to be statistically significant. So this is one of the pentacam pictures of our patient. This is the actual sagittal curvature of the patient. Now this is how the ablation Now this is the ablation pattern in during the procedure in the MEL 90 excimer laser. And this is the post-operative pentacam results of the patients of this particular patient at 1 year. As you can see, the preoperative Kmax was 56.2 diopters, and the post-operative Kmax at 1 year is 48.4 diopters. So there is a 7.8 diopter flattening which has been seen in this particular patient. Coming to discussion, in a case series done by Kaimenas et al., all the parameters which are analyzed, that is spherical equivalent refraction, uncorrected, best corrected visual acuity, and the mean keratometrics showed a significant improvement that remained stable throughout the follow-up period of 2 years. In a retrospective cohort study conducted by Sakla et al., significant improvements in corrected distance visual acuity, flat and steep K readings from pre-operative levels were apparent as early as 1 month after the procedure. In a comparative interventional study, a group that underwent topo-guided PRK with CXL was compared to another group that underwent CXL alone by Contadikis et al. Both steep and flat keratometry readings were significantly fatter in the topo-guided PRK CXL group compared with the CXL group. So coming to the conclusion, it has been proven that corneal collagen cross-linking is effective in halting the progression of keratoconus and in many cases helps to avoid corneal transplantation. However, it does not improve the refractive status of the eye. Also, the flattening produced by CXL is not a very predictable flattening. So when we can PRK with CXL, patients will obtain stabilization of the disease due to CXL, and also they will obtain functional vision due to the topo-guided PRK which we are performing. So we can conclude by saying that it's a very safe and effective surgical alternative for keratoconus, which yields improvement in uncorrected and best corrected visual acuity. These are my references. I would like to thank the summit for providing me this opportunity to present my paper. Thank you.
Okay, well done study. I have a question for you.
Yes, sir.
So what was the maximum amount of corneal tissue that was removed in your study during ablation?
Sir, in our study, we have done ablation up to 89 microns, sir.
Okay. 89
So,
microns.
Yes, sir. So, but this patient had a corneal thickness which was around 510, sir.
That means it was a very mild or form.
Yes, sir. Only we have included only mild and moderate keratoconus patients in our study. So this particular patient had very mild keratoconus, sir.
So what were your inclusion and exclusion criteria?
Sir, basically when it came to pachymetry, we took patients with thickness of more than 450 microns, because at the end of the procedure, we wanted patients to have a residual stromal bed thickness of at least 350 microns. That was our safety criteria. And patients, since we are performing refractive correction, we also took patients who are above the age of 18 years, sir.
Why 350 microns?
Sir, according to the safety algorithm that is provided in the CRS master, it does not allow you to ablate tissue below 350 microns, sir. That is the safety criteria which has been kept.
Okay. The maximum amount of tissue that you removed was 89.
Yes, sir. That is for one particular patient. 89 microns we have removed, sir.
Okay. So in a patient where you have removed 250 microns, I mean, where you are left behind a stroma of 350 microns,
Yes,
what was
sir.
the protocol that you used to do cross-linking?
So for such patients, we used hypotonic solution, sir.
But you didn't mention that already.
Okay. Okay, sir. Yes, sir. So if the residual stromal bed thickness was more than 400, we have used isotonic solution, riboflavin. If it was between 350 to 400, we have used hypotonic riboflavin solution, sir.
So that's the very question they asked. So if you have to go beyond 400,
Yes, sir.
The goal study was to make the cornea slightly on the regular side.
Yes, sir. To
correct
regular.
the refractive, not to correct the complete refractive error.
No, sir. We
So
have
there is
aimed to
only-
regularize the cornea so that patient will obtain some amount of refractive correction, but we have not aimed for complete correction, sir.
Yeah, that's why there is no need to go beyond 400.
Okay, sir. Okay, sir.
So you need to be above that safety net of 400 always.
Okay. Okay, sir.
No need to go beyond that.
Okay, sir.
Okay. Okay. Thank you.
Thank you so much, sir.
Yeah, we'll move to next speaker.
Hello, can I share my slides, sir? Hello, good morning, everyone. Today, I'm going to present a case series of COVID-19 vaccination-related acute endothelial rejection in penetrating keratoplasty. I would like to thank COSCON for this opportunity, and I would like to thank Dr. Mamta ma'am and Dr. Rekha ma'am for their valuable guidance. So, as we know, COVID-19 pandemic has affected several aspects of healthcare system, and ophthalmic practice is no exception. And the government has taken stringent efforts to curb the spread of pandemic by mass immunization. So we know, though the vaccine has been proven to be safe and efficacious, it also comes with minor immunological adverse effect when it comes to corneal transplantation. We know the corneal graft rejection rate is varying from 2.3% to 68% depending on the risk factors. So to a bit about the vaccination and immune response, literature already shows that vaccination has been proven to be a trigger factor for corneal graft rejection in the past, especially flu shots for influenza. And we know that vaccination incites immune response that can induce class 2 MHC complex in all the three layers of the cornea, which can trigger allograft rejection. And the recent rampant vaccination against COVID-19 has triggered a debate about such effect on endothelial or full thickness keratoplasty. So a bit about Covishield vaccine. So today's talk, all our patients had taken Covishield vaccine. So I'm just going to talk about only Covishield vaccine. Till date, 80 crore people have been vaccinated in India and 48 crore have received both the doses. And in this case series, we discuss presentation of corneal graft rejection following COVID-19 vaccine, that is Covishield, developed by Serum Institute of India. This is a viral vector vaccine carrying SARS-CoV-2 spike protein, and this vaccine has demonstrated high levels of neutralizing antibody titers and antigen-specific CD8 plus and CD4 plus T cell responses. So we included 4 cases with all the cases were on maintenance dose of topical steroids, and 1 patient was on tapering dose of post-operative steroid regimen for penetrating keratoplasty, and all cases presented to us with diffuse endothelial rejection. So going to the details of each case, age varied from 22 years to 70 years, and all patients had undergone penetrating keratoplasty. Our first case is 70-year-old female who had undergone penetrating keratoplasty for pseudophakic bullous keratopathy, and her graft duration was 18 months, and her pre-vaccine visual acuity was 6 parts. She presented to us 25 days after the vaccination. However, she presented to us 10 days delayed from her initial symptoms with visual acuity of 660. And we started her on intensified topical steroid regimen. However, we again lost her for follow-up for another 2 months due to the second lockdown. And she presented to us after 2 months with severe graft edema and endothelial rejection, drop in vision to CF 2 meters. And hence we had to start her on oral steroids as well as topical and subconjunctival steroids with intensive treatment. However, we achieved her clear graft within 4 months of her initial presentation with final visual acuity of 612 parts. Coming to the second case, a male who underwent PKP and his graft duration was 5 months. His vision was 6/9 and he presented 4 days following the vaccination and immediately following the initial symptoms with his visual acuity at presentation was 6/9 parts. And again, we put him on only on topical intensive steroids, and he resolved within 3 weeks with the pre-vaccine visual acuity of 6/9. Case 3, again, she had undergone penetrating keratoplasty in both eyes, and this particular eye, graft duration was 39 months, and her visual acuity was 6/9, and she presented 13 days after the vaccination, within 2 days after the initial symptoms, and her visual acuity at presentation was 6/12. And she also resolved within 4 weeks with the pre-vaccine visual acuity of 6/9. And other eye also had undergone PK, showed no signs of rejection during her initial presentation. However, we started her on prophylactic topical steroids. So far, both the eyes are doing fine. And last case, he is undergone PKP for keratoconus, and his graft duration was 3 months, and his visual acuity was 636. He presented to us 9 days following the vaccination, and his visual acuity was 660 during presentation. He also resolved within 6 weeks of the initial presentation and improving to 636 with clear graft. And he also took second dose of vaccination 9 weeks following the resolution with prophylactic topical immunosuppression, showed no signs so far, no signs of rejection so far. So these are the pictures showing endothelial rejection with keratic precipitates and anterior chamber reaction, typically with resolution showing clear graft. So coming to the discussion, in our case series, we observed a resolution time of 3 weeks to 4 months, and we did not lose any of the grafts. In the literature, there has been reports about the graft rejection following immunization. Steinman et al. Has reported case series of corneal graft rejection following immunization for hepatitis B, tetanus toxoid, and also influenza. And Wesser et al. Has reported 2 cases of graft rejection following COVID-19 vaccine. He also observed a resolution time of 3 weeks to 4 weeks. Filacto et al. Reported 2 cases of graft rejection following COVID-19 mRNA in DMEC patients with resolution of 4 weeks and 7 days in both the cases. And Rallis et al. Has reported a case of a single case of endothelial rejection in patient with bilateral dissect, with one eye showing graft rejection and other eye has remained healthy with resolution time of 3 weeks. So a bit about allograft rejection. On exposure to activated T cell products, we know class 1 MHC cells are induced in the corneal epithelium and stroma. However, much stronger class 2 MHC can be induced in all the 3 layers of the cornea. So there are 3 possible mechanisms of allograft rejection. One, local inflammatory response by which soluble immune complexes are deposited in the uvea and the perilimbal vasculature, leading to inflammatory products like interferon and interleukin, other lymphokines reaching the graft tissue, which causes MHC expression and thereby causing allograft rejection. And another mechanism could be systemic release of gamma interferon, which can reach the graft tissue along with the activated T cells and causes MHC expression followed by allograft rejection. And the third possibility could be production of T effector cells, which can cross-react with the allo-MHC complexes already existing in the donor cornea, causing allograft rejection. So with this, I conclude that our case series highlights the possibility of immune corneal graft rejection following COVID-19 vaccination, which all corneal surgeons should be aware of. And with this, it also leads to a dilemma of what is the timing of the vaccination in a post-grafted patients, and should we follow any standard prophylactic treatment regimen, and also timing of the second dose of vaccination in already presented rejection cases with the post-vaccine, and can we also give oral immunosuppression in high-risk cases. So thank you. These are my references.
Are there any limitations for this study?
Ma'am, actually, there is no set of protocol we followed, because one patient, since she presented to us late and also there was poor compliance, she didn't follow up well. So we had to start her on oral and topical as well as subconjunctival steroids. However, rest of the cases we achieved a clear graft with just topical steroids. So there is no set of treatment protocol that we followed. It's only according to the patient presentation and duration we followed the protocol.
How do you know that the rejection was due to vaccination, not due to anything else?
Ma'am, all the patients who presented to us were already on the maintenance dose of steroids, and also the temporal association of their presentation to the vaccination date suggests that that could be the possible reason.
Okay, thank you.
Thank you, ma'am.
Next speaker, can you share your screen?
Yes. Excuse me, I have a doubt. I was supposed to go next. Okay. Can I start sharing my screen?
Yes, doctor.
Good morning. At the outset, I would like to thank COS for giving me this opportunity. I'll be going to present on evaluation of the interdevice variability of the central corneal thickness measurement using IOL Master 700 and Ceres ASOCT in comparison to Pentacam in healthy eyes. Accurate measurement of the central corneal thickness is of essential importance in ophthalmological examination, and also pre-operatively, it helps the ophthalmologist to safely plan the corneal refractive procedures and screen the candidates accordingly for the refractive surgeries, as this measurement determines the amount of strova that can be ablated safely to avoid post-operative complications. It is also important for monitoring the corneal endothelial function. Besides, CCT measurements also help in the diagnosis and further management of glaucoma, since the intraocular pressure value should be adjusted according to the central corneal thickness. The normal CCT is around 490 to 560 micrometer, and cornea is thickest at the limbus. It also plays an important role in diagnosing various corneal conditions such as Fuchs corneal dystrophy, keratoconus, etc.
Excuse me, doctor. Doctor, we are not
Yes.
visible with your screen.
Just a second.
Yeah.
Is it visible now?
No, it's not visible.
Is it visible now?
Yes,
Yeah,
yes.
yes.
Can I start over there?
Yes,
Or
yes.
shall I continue?
You continue, ma. Continue.
Okay, sir. Ultrasound pachymetry is currently the most common method used to measure central corneal thickness. However, it is subjective and operative dependent. Therefore, the non-contact methods of measuring the CCT are gaining importance. Hence, the intraoperator repeatability, interoperator reproducibility, and accuracy of the measurement of CCT using different methods is of special concern. The objective of the study is to assess the intra-observer repeatability, interchangeability, and accuracy of CCT measurements done by Zeiss IOLMaster 700 and Carl Zeiss Cirrus HD OCT 500 anterior segment OCT spectral domain in comparison to the 3D Schindler corneal tomography Oculus Pentacam. Methodology. It is a cross-sectional study conducted at a tertiary care center and included healthy subjects with healthy corneas of either gender aged between 18 to 40 years. A total of 240 eyes, 120 subjects were evaluated and central corneal thickness was measured using Pentacam, ASOCT, and IOLMaster. The mean central corneal thickness plus or minus standard deviation for Pentacam, IOLMaster 700, and ASOCT were 523.75 plus or minus 27.75, 525.29 plus or minus 28.81, 517.13 plus or minus 28.43 respectively. This is a table showing mean central corneal thickness and standard deviation of all instruments. Pentacam having a mean central corneal thickness of 523.75 with minimum CCT of 457 and maximum CCT of 596, standard deviation being 27.75. Anterior segment OCT having mean central corneal thickness of 517.13 with mean CCT of 456 and maximum central corneal thickness of 607, standard deviation of 28.43. IOLMaster mean CCT 525.29, minimum 458 and maximum of 603 with standard deviation of 28.81. All the means were significantly different from one another. The differences between pairs of mean CCT for Pentacam and IOLMaster, Pentacam and ASOCT are statistically significant. Bland Altman plots showed that Pentacam and IOLMaster 700 had the closest agreement, followed by ASOCT. This is a table showing differences in the mean of Pentacam and others. This is a table showing Pearson's correlation. Bland-Altman plot of IOLMaster with Pentacam showing close relation. Bland-Altman plot of ASOCT and Pentacam. Discussion. There are different methods available to measure central corneal thickness in normal and diseased eyes. Newer devices have made central corneal thickness measurement easy and safe in routine ophthalmological examination. The two most important factors in monitoring an individual patient require high repeatability and reliability of that particular instrument, thus standardizing the instrument. Interchangeability between different available instruments to measure CCT is of utmost importance. The two potential sources of error in measurement of CCT is human and instrument itself. Barkana and co-authors reported an excellent repeatability and reproducibility for the Pentacam Schindler device, hence stating that it gives a reliable estimate of the central corneal thickness. A single reading is sufficient and independent of the operator. In this present study, the differences in the pachymetry values from different instruments were statistically significant. Hence, the CCT measurements by Oculus Pentacam were statistically higher than that of Cirrus ASOCT and statistically lower than that of IOLMaster 700. And the interchangeability of the CCT values between these methods is not possible because of the bias and wide variation, which can be largely attributed to the distinct methodologies of the measurement technology. Conclusion. The CCT measurements of the Pentacam did not correlate with that of IOLMaster or ASOCT. Therefore, in clinical practice, the devices analyzed should not be used in interchangeability due to low agreement regarding CCT values. However, repeatability and reproducibility of the individual devices is possible. These are my references.
Well done, study, Dr. Kinnan.
Thank you, sir.
If you don't have any more questions, then we'll proceed to next speaker.
Good morning. Good morning, sir. Good morning to everybody here.
Share your screen.
Yes, sir. Is it visible now, sir?
Yes, yes.
Good morning to everybody gathered here. Today I'm going to present a paper on chronic ocular complications of Stevens-Johnson syndrome in a retroviral positive female. Financial disclosure was nil. Stevens-Johnson syndrome is a severe immunologic dermatobulous condition with high morbidity and mortality. Ocular surface is one of the major targets and patient may become irreversibly blind. Acute ocular involvement is reported in 50 to 88% of SJS cases. Amniotic membrane transplantation, aggressive topical antibiotics, and lubrication in acute stage are necessary to prevent long-term sequelae. If chronic ocular disease does occur in about 30 to 50% of the cases, several interventions can be employed to prevent progressive vision loss and discomfort. Earliest interventions are the ones most likely to prevent chronic complications. Here we describe a case report of 47-year-old HIV positive female patient with SJS who had severe chronic ocular complications. A 47-year-old female who was a known case of SJS with HIV positive status had 2 years ago, patient had taken medication cotrimoxazole for her gynec-related condition, following which she had developed skin and ocular reaction, which was diagnosed as SJS. She was referred to the ophthalmic department for her eye condition. She had complaints of pain and photophobia in the right eye more than the left eye. Right eye on examination had symblepharon, ankyloblepharon, and paracentral corneal epidefect. Left eye had symblepharon. Both eye lid margin keratinization was there. Visual acuity in the right eye was 20 by 100 and left eye was 20 by 80. So this is a diagnosis of a SJS sequelae and treated with intensive topical lubricants. Confirmed seropositive status, started heart therapy. Patient visited us after 2 months with diminished vision. Right eye had paracentral corneal thinning with poor eye surface. Left eye had central perforation, corneal perforation with shallow AC. In view of lateral symblepharon in the left eye, bandage contact lens is unlikely to stay. Hence, TA with BCL was not advised. Left eye amniotic membrane graft transplanted. Post-op day 1 AC was well formed. On day 10, suture was removed and patch was in situ. Visual acuity in the right eye improved to 20/60 and the left eye was 20/60. Medical treatment on discharge were tear drops, eye mist gel, Predford drops, prednisolone acetate, Acupol D ointment, chloramphenicol with polymyxin and dexamethasone, and Milflox eye drops were prescribed. Patient was lost to follow for 3 months when she came with complaint of pain, watering, and redness in the right eye. Visual acuity in the right eye had deteriorated to counting fingers 1 meter and left eye was 20/60. Left eye amniotic graft in situ. Right eye on examination, there was paracentral corneal perforation inferior medially. Hence, a corneal patch graft was done with AC reformation and with glue and BCL was applied. Post-op day 1 AC was well formed. Follow-up after 10 days, right eye had total cataract and visual acuity deteriorated to hand movements. Follow-up after 1 month, visual acuity in the right eye was only perception of light. However, in the left eye, it was retained to 20/50. Follow-up after 1 month. Later, right eye showed corneal perforation, which was treated with glue and BCL. Post-op day 1 AC was shallow but formed, and visual acuity in the right eye was PL. PL was perception of light was positive and projection of rays were inaccurate. However, vision in the left eye remained 20/50. Patient lost for follow-up after 4 months until 4 months when patient came with right eye on examination, cornea had total opacification. On examination, left eye had symblepharon with lid margin keratinization, which was treated with mucous membrane graft for the 2 eyelids. Follow-up after 2 months, patient had severe pain in the left eye. Left eye on examination, cornea had central graft with iridocorneal adhesion. Visual acuity on examination, right eye, no projection of light, and left eye had deteriorated to 20/800. Left eye, PROS extended trial was done and the vision improved to 20/125 with PROS lens. After 2 months, patient came with acute onset of pain, bilateral edematous eyelids, conjunctival hyperemia, and worsening pseudomembranes with left corneal infiltrate which threatened her vision. Right eye was blind, cornea was totally opacified and with vascularization. Left eye had perception of light and projection of rays and showed paracentral corneal epidefect with ring infiltrates. This is the image which showed. This is the image of the right eye, which wherein cornea was opacified with vascularization and corneal scars is present. Investigations revealed microbial gram-positive cocci keratitis in the left eye. B scan was done where right eye report was thysis bulbi and left eye there was no evidence of endophthalmitis. Patient was treated with topical antibiotics, lubricant, atropine eye ointment, oral acetazolamide and oral NSAIDs. However, left cornea perforated on day 5. This is the picture of the left eye on day 5, showing paracentral perforation, conjunctival hyperemia, edematous eyelid. So patient was planned for amniotic membrane grafting, but patient was not willing for any kind of further intervention and went against medical advice. So, discussion. SJS is a severe potentially blinding disorder secondary to T-cell mediated dermatobullous drug reaction. Recent advances in the treatment of ocular manifestation of SJS in both acute and chronic stages of disorder make ophthalmologists critical player in its initial and long-term management. There are several windows of opportunity in management of SJS, which if missed result in irreversible ocular damage with attendant discomfort and loss of visual function. First window is upon admission to burn ICU. A detailed eyelid and ocular surface examination is critical to determine if indications for amniotic membrane grafting have been met. Second window of opportunity occurs after discharge from hospital when failure to correct seemingly minor eyelid abnormalities such as trichiasis or eyelid malposition can allow progression from corneal epitheliopathy or simple corneal epithelial defect to corneal neovascularization, opacity, and potentially corneal perforation. Posterior eyelid margin keratinization at any time after acute episode should lead to immediate referral for scleral lens treatment or mucous membrane graft surgery. Finally, corneal blindness due to SJS represents a window of opportunity for restoration of vision. However, mismanagement by inappropriate surgery or inadequate post-op care can result in irreversible blindness without hope for later restoration. Thank you. Hello, sir.
Yeah.
Hello, ma'am.
A very well detailed study here, doctor.
Yes, sir. We had followed up this patient for 2 years, sir. But patient in between was not compliant. She was lost to follow up.
Yeah. Congratulations on that very detailed study.
Thank
Good.
you. Thank you.
Madam, patient had
Yes, ma'am.
what did the patient have? Toxic epidermal necrolysis or just Stevens-Johnson syndrome?
No, ma'am. SJS sequelae only patient had not progressed to toxic epidermal necrolysis stage.
Okay. Can you tell what is that first window of opportunity? What do you do in acute phase?
Immediately after diagnosis of
Yeah.
SJS, check for ocular surface abnormalities, ma'am, like trichiasis or entropion, which can be
What
treated
drops
with
you
punctal
give?
occlusion. Adequate aggressive lubrication should be prescribed
And
with topical antibiotics.
and
Mm.
yeah, you said that in your slide. That's why antibiotics and lubricants. Don't we give steroids?
Yes, ma'am.
Yeah, we should.
Yes, we should give steroids. Yes.
Yeah, can you tell me why patients will go for sequelae and complications? Because that first window is missed.
Yes, ma'am. In SJS, it is a like a T-cell mediated immune sensitivity reaction to drugs, where there is dermatobullous epidermal intraepidermal necrosis.
Okay, fine. Saida, madam, can you tell me what is the full form of PROS?
Yes, ma'am. Prosthetic ocular surface ecosystem.
Thank you.
Next speaker.
Can I share my screen?
Yeah, you can share your screen.
My paper presentation is on exposure keratopathy, prevalence, risk factors, and impact of protocolized care in a tertiary intensive care unit. So exposure keratopathy, as we know, is damage to cornea that occurs primarily from prolonged environment. So there are various protective mechanisms which everyone have to prevent this exposure keratopathy, like the position of eyelids, tears, blink reflex, and protective bells phenomena. But in sedated and ventilated critically ill patients, they have impaired protective mechanisms, making them susceptible to develop this exposure keratopathy and microbial keratitis. So, as I said, there are a myriad of risk factors that predisposes the critically ill patients to exposure keratopathy from iatrogenic causes such as mechanical ventilation, sedation, and muscle relaxants, and certain patient factors such as reduced consciousness, reduced tear production, decreased blink rate, impaired corneal reflex, incomplete eye closure, and vascular permeability. So the exposure keratopathy rate in critically ill patients has been reported as low as 10% to as high as 55 to 60%. So although usually EK resolves once a patient recovers, it's a distressing condition and can cause corneal scarring and permanent visual loss. and it can even precipitate microbial keratitis, leading to acute perforation, endophthalmitis, and permanent visual impairment. So the aim of our study was to assess the prevalence of exposure keratopathy and to identify the risk factors and emphasize the need of a protocolized care in a tertiary intensive care unit. So exposure keratopathy was assessed by corneal staining with 1% sodium fluorescent strip and graded according to severity using indirect ophthalmoscope, cobalt blue filter. The duration of stay in the ICU, sedation score, that is RASS score, ventilation status, and GCS was noted. The patients were receiving prophylaxis to prevent exposure keratitis as per the ICU protocol, and the right eye data was used for purpose of analysis. So the results, the study included 42 patients. The mean age was 59.2 years with 29 males and 13 females. And as per the protocol, 33 out of 42 patients were receiving tear substitutes and 3 of them were undergoing patching. The number of intubated patients was 17 out of 42. So exposure keratopathy was detected in 23 patients, that is 54.8%, with mild exposure keratopathy in 17, that is they had punctate epithelial erosions, moderate exposure keratopathy in 6 patients, that is they had macroepithelial erosions, and none of them had severe exposure keratopathy. So factors found to be associated with increased occurrence of exposure keratitis were duration of ICU stay, deeper sedation, low GCS score, and ventilation. So the relevance is, despite the existing exposure keratopathy prophylaxis protocol, there is mild to moderate EK occurring in almost 50% of patients, although it prevented severe exposure keratopathy. So in the ICU setting, the medical staff is primarily concerned with stabilization of vital body functions. So what happens is, because of the lack of awareness about exposure keratopathy and failure to perform regular ocular screening, these disorders go unrecognized. So by simply raising an awareness of the eye care through education, then periodic retraining and reinforcement of the protocol among the healthcare professionals working in ICU itself can reduce the rate of exposure keratopathy substantially. Furthermore, formalized guidelines and protocols, when incorporated in patient care plans, can significantly reduce the rate of exposure keratopathy. Thank you. Hello.
Yeah, I have no questions.
Okay.
Yeah, then we'll move to next speaker.
Okay.
Hello. Hello, sir.
Yeah, start. Share your screen, please.
So is it visible now?
Yeah, start.
Good morning, sir. So I'll be presenting the paper on effect of allergic conjunctivitis on central corneal thickness and intraocular pressure. We don't have any financial disclosures here. So allergic conjunctivitis is a group of ocular allergic reactions which include seasonal allergic conjunctivitis, perennial allergic conjunctivitis, which are acute in nature, and vernal keratoconjunctivitis and atopic keratoconjunctivitis, which are chronic in nature. Giant papillary conjunctivitis due to contact lenses or other ocular processes is also included in this classification of ocular allergies. There are studies which show the evidence of close association between the allergic conjunctivitis and keratoconus. Eye rubbing, itching, itchy eyes, allergic conjunctivitis are said to be the risk factors for keratoconus, and it has also been proven that these factors increase or exacerbate the keratoconus progression. Characteristics of keratoconus include the corneal stromal thinning and corneal protrusion. Thus, the central corneal thickness is one of the important indicators of overall corneal health and helps in the early diagnosis as well as of keratoconus and early tool for diagnosis of primary open-angle glaucoma 2. The study is undertaken to evaluate the central corneal thickness and... Hello?
Slides are not moving. Your turn.
Sir, now is it visible, sir? The objective of my study? Hello.
No, Soumya, it's not moving. You put on slide share and we are, yeah.
Ma'am, is the introduction slide visible now?
Yes, yes, introduction slide. Put on slide share, please.
Now?
Yes, we can see objective.
Yes, ma'am. Shall I continue from here, ma'am, or should I start from the beginning?
Continue.
Okay, thank you, ma'am. So the objective of our study is to evaluate the central corneal thickness and intraocular pressure in the patients with allergic conjunctivitis. The methodology, it's a hospital-based case control study which was conducted in 70 eyes, in which 35 eyes of 20 patients had allergic conjunctivitis and 35 eyes were of control population. So detailed ocular examination was done, which included history, systemic examination, vision, refraction, detailed fundoscopy, central corneal thickness, and intraocular pressure were measured using ultrasound pachymetry and Goldman's applanation tonometry, respectively. Comparison of the values was done with the healthy individuals. The inclusion criteria included the patients who gave informed consent, patient with a history of itching, redness, irritation, chemosis, eyelid edema, and the presence of clinical signs like papillae, giant papillae, micropapillary conjunctivitis, trichiasis.
Yes, slides are not moving, Soumya.
Now? Hello?
Karthik, sir, for you, it's moving.
No, ma'am, it's not moving. Can you just keep entering the one after the slides ending? If you finish one slide, you can enter, keep entering the, press enter the key, then it will move.
Sir, which slide is visible right now for you? May I know that?
Inclusion and exclusion criteria.
Sir, I was presenting this slide only. Now is it visible in full screen?
Not at full screen. You need to do the full screen. Yeah, do full screen now.
So now?
No. Click on that button for the full screen.
Now, sir?
Not visible. Okay, anyway, you can, if you can present it in this way also, it's not a problem. You
okay, sir.
Carry on.
Yes, sir. Thank you. So the inclusion criteria included the patients who gave the informed consent, patient with a history of itching, redness, irritation, eyelid edema, chemosis, presence of clinical signs like papillae, giant papillae, micropapillary conjunctivitis, trichiasis, entropion, and symblepharon. The patients who did not give consent and who had corneal epithelial defect were the exclusion criteria. They were not included in the study. Coming to the results part, the study age distribution, the study group showed that the 35 eyes of 20 patients with a mean age of 25 years with a standard deviation of 9.2 years, and the control group consisted of 35 eyes of 35 patients with a mean age of 27 years plus or minus 10 years. The gender distribution, out of 35 eyes of the control group, 12 patients were male and 8 patients were female. Control group had 35 patients with 18 males and 17 females. Best corrected visual acuity of all the patients was 624 or better, and there was statistically significant difference in the best corrected visual acuity between study group and the control group. Association with the systemic diseases showed that out of 20 patients in the study, one patient had atopic dermatitis. There was history of bronchial asthma in 5. eczema in 6 patients, and 2 patients were using contact lenses. The mean central corneal thickness in the study group was 521 micrometer with standard deviation of 5.9, whereas in the control group it was 542 with standard deviation of 5.42. Analysis by t-test showed the difference in the mean CCT between the study and the control group, which was statistically significant. The mean IOP in the study group was 17 millimeters of mercury, and in the control group was 11. There was no statistically significant difference found between the control group and the study group. Coming to the discussion, in our study, we analyzed the age group of 15 to 20 years of age were susceptible to allergic conjunctivitis and male preponderance was seen. We found that eczema was most commonly seen in the study group. The giant papillae was the most common clinical sign, and the mean CCT in the study population was lesser compared to the control group. And IOP did not show any significant changes in the study group and the control group, as the patients included in the study were on olapatadine and not on steroids. In the study done by Ondas et al., a study group of 60 eyes of 30 patients were compared with 60 eyes of 30 control, which showed the mean age of 37 years in the study population and constituted more of females. When compared with this study, the study population is of slightly elderly age group than our study, and it constituted more females than males. The mean CCT in the study group was 523, and in the control group was found to be 540, which corresponded to the results in our study. Study done by Dogan et al. Compared 40 healthy participants with 40 allergic conjunctivitis, which constituted mean age of 26 years and 25 years respectively. And CCT was found to be thinner in the study population, but did not show any statistically significant difference between the two populations. Coming to the conclusion, the central corneal thickness plays an important role in the diagnosis of keratoconus at the early stages, and therefore measuring central corneal thickness must be a routinely done investigation in cases of allergic conjunctivitis. Measuring intraocular pressure too plays an important role, as most of the patients with severe non-resolving symptoms are started on steroids. These are my references. Thank you. I thank each and everyone who has given me this opportunity to present my paper, and sorry for the technical glitches.
Okay, doctor, why do you think the corneal thickness was lesser in allergic group, and also why the IOP was slightly on the higher side, even though it was not statistically significant in the allergic?
Yes, sir. So,
what is the reason?
Repeated eye rubbing that happens in the allergic conjunctivitis patients, there are certain theories which have been proved that there are certain enzymatic actions which take place, which lead to degeneration of this corneal stromal thickness. This corneal stroma goes on reducing in this allergic conjunctivitis patient due to the release of these certain enzymes. And this was one of the enzymatic theory. Other would be the mechanical theory, and intraocular pressure is also high, is found to be high in most of the cases of allergic conjunctivitis, as most of the chronic allergic conjunctivitis patients are started on steroids. So.
Yeah, correct. And they do not follow up.
Yes,
most
sir.
of
They
them
don't
wouldn't
follow up. Yes, sir.
And they would be continuing topical steroid as and when they require.
Yes, sir.
So when they visit you, you will find that most of them have raised IOP. Yeah. So if there's no other questions, then we'll thank you, Dr. Akshata.
Thank you so much, sir.
Next speaker, please.
Hello, myself, Dr. Vinita.
Yeah, Dr. Vinita, start your slides.
Is my slides visible?
Yes, start.
So good morning, everyone. At the outset, I would like to thank COSCON for giving us this wonderful opportunity to present today. So today I'll be presenting on accelerated collagen cross-linking in pediatric keratoconus, no financial disclosures. So as we all know, keratoconus generally occurs during puberty, and progression of keratoconus is aggressive in young patients when compared to adult KC patients. Collagen cross-linking has been found to be effective in halting the keratoconus progression, and the standard Western and accelerated collagen cross-linking. Hello?
Hello, Dr. Vinita. Your slides are not moving.
Not moving, sir.
Can you make it a full screen?
Yeah, it is full screen now. Now?
Not.
Now, sir?
Yeah, now it's moving.
I think I'll continue with like this.
But it was.
You please continue. Please continue.
Yeah.
Let's not waste time.
So collagen cross-linking has been found to be effective in halting the keratoconus progression, and the standard Western and accelerated collagen cross-linking procedure have comparable results in pediatric keratoconus. So this is a cross-sectional study done on 30 eyes of 30 pediatric progressive keratoconus patients with a mean age of 12 years. Preoperative visual, refractive, and topographical evaluation was done. All the patients underwent accelerated collagen cross-linking, 22 patients under general anesthesia and 8 under topical anesthesia. The postoperative visual, refractive, and topographical follow-up was done at 1 year and 2 years after the procedure. Coming to the results, the mean uncorrected visual acuity and the best corrected visual acuity showed statistical significant improvement at the end of 1 year and remained stable at the end of 2 years as well. When we compared the mean spherical equivalent compared to pre-op, the post-operative at the first year and the second year showed mild improvement, but there was no statistical significant improvement in the spherical equivalent. The mean K1 and K2 compared to pre-operative showed statistical significant flattening at the end of 1 year and remained stable at the end of 2 years of follow-up. So coming to the topographic outcome, when we see the change in the mean anterior and the posterior elevation compared to pre-operative, there was statistical significant change at the end of first year, and that also remained stable at the end of 2 years of the follow-up. The change in mean K max was has also shown statistical significant reduction at the end of 2 years. When we see the thinnest pachymetry, the change was very minimal at the end of 1 year, but it also returned to the normal baseline values at the end of 2 years of follow-up. So when we compare the efficacy, coming to discussion, when we compare the efficacy in terms of best corrected visual acuity in logMAR units of accelerated cross-linking in pediatric age group, our present study showed consistent results with the previous studies done by Tian et al., Banninger et al., Ozge Sarak, and Uliso et al. When we compare the efficacy in terms of change in mean K max in pediatric group, our study showed 4.16 reduction in K max, whereas the previous studies have shown reduction comparable from 1 diopter to 4 diopters. So this is a table showing the various published studies regarding outcome of collagen cross-linking in pediatric age group who have followed both the standard protocols and the accelerated protocols, all of which have shown much stabilization over the periods of 1 to 4 years. And our present study also showed a consistent results with these studies. So to conclude, this study showed significant stabilization and improvement of visual as well as topographic outcome of the accelerated collagen cross-linking in pediatric keratoconus group. Our study reinforces the previous studies on the efficacy of accelerated collagen cross-linking in children as a modification of standard protocol. These are my references. Thank you.
Yeah, and doctor, were there
Yes.
any cases of recurrence in your study?
No, sir. Whatever we studied, these 30 eyes, there were no recurrences. The other eye status, few patients had early keratoconus, and few patients underwent DALC because of recurrence. But whatever the 30 eyes we took in this study, these people who underwent accelerated collagen cross-linking did not show any recurrence.
How long was the follow-up?
2 years, sir.
Okay, so in 2 years there were no changes
No,
for the
no,
worse.
no, sir, no recurrence.
And all of the cases underwent accelerated, none of them
Yes.
standard.
No, sir. All of them underwent accelerated collagen cross-linking.
Okay, fine. Thank you.
Thank you, sir.
Shall we move to next speaker?
Can you start, sir? Hello.
Yeah, please start.
Hello. Everyone can see the slides.
Yeah, start, please start.
Hey, my paper presentation is on corneal endothelial morphological characteristics. A comparative study on diabetic cornea. Introduction: diabetes mellitus, both insulin dependent and non-insulin dependent, is a major public health concern in this modern day and is a fast-growing potential health disease in India. Diabetes mellitus causes loss of vision not only from major abnormalities of the retina and lens, but also from the alterations in the cornea, tear film, eyelids, iris, ciliary body, and retinal nerves. 70% of the diabetics suffer corneal complications collectively called diabetic retinopathy. My objectives of the study are to study the age-related changes in corneal endothelium in patients with type 2 diabetes mellitus compared to normal individuals in age group of 40 to 78, such as central corneal thickness, corneal endothelial cell density, average cell size, and examination. Materials and methods. Study design is a cross-sectional comparative study, and the sample size is 120 eyes of 120 patients. In the source of data, patients who fulfill the inclusion, exclusion criteria coming to our department. And the duration of study is 2 years. Inclusion criteria includes patients in cases are patients in the age group of 40 to 78 who are diagnosed with type 2 diabetes mellitus were included. The diagnosis of diabetes mellitus will be based on the criteria of American Diabetes Association and include all patients who are already under the treatment of physician. Control group: normal healthy age who do not have diabetes mellitus. Subjects with fasting blood sugar of less than 110 milligram. Patients with diabetes and healthy individuals who are willing to be considered for the study. And the exclusion criteria includes patients with the type 1 diabetes mellitus, high myopia, glaucoma, history of past ocular surgery or trauma, history of corneal disease or corneal dystrophy such as fused endothelial dystrophy, systemic illness such as rheumatoid arthritis and systemic lupus erythematosus that are known to impair tear function, and patients who are not willing to give consent. The corneal endothelial cell structure and central corneal thickness will be examined in all patients by non-contact specular microscope using EM3000 specular microscope, and is done by a single examiner. The endothelial structure will be studied by measuring a variety of factors including central corneal endothelial cell density and coagulatory cell size and extremity. The measurement will be done 3 times and the average will be taken. In both cases, SS controls will be divided into 3 Qs based on age 40 to 49, 50 to 59, 60 to 70 years. On the result part, we will the central corneal thickness on the diabetic group is 547, and in the control group it is 539, and the endothelial cell density is 2479 in the diabetic group, while in the control group it is 2656, and the average cell size is 374 in the diabetic group, and it is 351 in the control group. And the examination is 30 in the diabetic group, and while the control group it is 33. So here in the you can see the graph that in the diabetic group it is 547, and the control group it is 539, and the endothelial cell density in the control diabetic group it is 2479, and control group it is 2656, while the average cell size is 374 in the diabetic group, while it is 351 in the control group, and the externality is 30.1, and in the diabetic group, well, it is 33.88 in the control group. So there is a significant difference between the main values of central corneal thickness, endothelial cell density, average cell size, and externality between the groups. And coming to discussion, in our study, the diabetic group showed a higher central corneal thickness as compared to normal individuals. A study conducted by Navies et al. Entitled on corneal thickness and endothelial cell length in diabetic and non-diabetic patients in post-based compared to study. The central corneal thickness was significantly higher as compared to the non-diabetic group. In a present study, the endothelial cell density is much higher in the control group and than the diabetic group. A study on the effects of diabetes mellitus on corneal endothelial cells and the central corneal thickness, a case control study done by Preoperative to evaluate the characteristics of corneal endothelial cells and central corneal thickness in patients with diabetes mellitus to compare them with those of healthy individuals and to determine potential factors affecting the corneal parameters in patients with diabetes mellitus. They concluded in their study that endothelial density was decreased in diabetic group, and the average cell area of diabetic patients was 374 plus or minus and 9.49. In our study, is more than that of the patients in the control group, 351 plus or minus 7.34. A study conducted by Noda and G.T. et al. Findings of corneal specular microscopy in patients with type 2 diabetes mellitus in 195 diabetes patients and 100 healthy patients. They divided the diabetic patients into groups based on the stage of diabetic retinopathy. They found average cell size is much higher in diabetic patients than in normal patients. This is similar to that of our study. Hexagonality of diabetic patients is found to be lower than that's non-diabetic patients in our study. A retrospective cross-sectional study conducted by Kim J.Y. in 511 type 2 diabetes mellitus and non-diabetic patients found that hexagonality was significantly lower in diabetic group than the control group, similar to our study. On conclusion, we observed that diabetes causes a lot of changes in human cornea and showed a statistically significant difference in the endothelial cell density, central corneal thickness, and average cell area, and the hexagonality. These are my references. Thank you.
Dr. Vishnu, why was the type 1 diabetes patient?
About this study.
Sir. Hello.
Yeah, Dr. Vishnu,
yes,
why was the type 1 diabetic patients were excluded from the study? What was the reason?
So, mostly type 1 is usually seen in the young patients, less than 40. I took the age group as 40 to 78, sir. So type 1 diabetes is mostly in young age we should take. So
was that the only reason why it was excluded, or there are any other reasons for it? Okay, if you don't know, then we'll go to the next question. Yeah, Dr. Rashmi, you can ask the next question.
Yeah, Vishnu, I was asking what's new in your study?
Actually, almost compared to study, our study too, sir. There's increased central corneal thickness, ma'am. Compared to there's not much difference between the other study, ma'am.
Okay, Vishnu, how will you apply this knowledge in your clinical practice?
Means how the means if the endothelial cell density is decreased, ma'am. If in intraocular surgery, if you do endothelial decompensation, if you pre-op, if you do specular microscopy, if the endothelial cell count is reduced, we can previously tell the patient that there's endothelial compromise already, and it can go for keratopathy like that. Bullous keratopathy after.
Thank you. Thank you. We'll move to next speaker.
Yeah. Next speaker, please.
Yeah, shall I share my presentation?
Yeah, next speaker. Who is the next speaker?
Yeah, I'm just sharing my PPT. Just a minute. There is some problem with sharing the. It is showing some error in uploading.
If there is a problem, then can we go to the next speaker who is already ready?
Yeah, can I present next?
Yeah, you can present.
I mean, after.
Yeah,
okay,
yeah, you can.
Hello, sir. I'm the next presenter, Dr. Jasmita
Yeah.
here, sir.
Yeah, present.
So, good morning to the panelists again. My second paper, I think the slides are not moving, so I'll just continue sharing like this, sir.
Problem. Go ahead.
My second paper is about long-term outcomes of corneal collagen cross-linking with riboflavin in patients with progressive keratoconus. A long-term study, which is a 5-year study. And again, I would like to thank Dr. Mamta ma'am and Dr. Rekha ma'am for their valuable guidance. As we know, and as already been discussed here many times, keratoconus is a bilateral non-inflammatory ectatic disease causing irregular astigmatism and marked impairment in the quality of vision. And according to the global consensus on keratoconus and ectatic diseases, progression of keratoconus is defined as steepening either in the anterior and the posterior corneal surface, or thinning and or increase in the rate of corneal thickness change from the periphery to the thinnest point. Wallenstock et al. Introduced corneal collagen cross-linking, and he proved that it is an effective treatment to halt the progression of the keratoconus. And majority of the panelists in the global consensus of keratoconus and ectatic diseases said that collagen cross-linking is the most commonly performed and currently available treatment for halting the progression of KC. So here I am to confirm the long-term outcomes of the collagen cross-linking in progressive keratoconus. So aim of my study is to evaluate the long-term 5-year clinical effectiveness of collagen cross-linking in progressive keratoconus. So all patients who were included in this study had documented progression, were only subjected to cross-linking. So it's a retrospective study, and preoperative history of systemic allergy, family history of keratoconus, and any allergic history were taken. Minimum follow-up, post-operative follow-up duration of 5 years was taken, and each visit parameters analyzed were best corrected visual acuity, refraction, corneal curvature by topographic analysis, and central corneal thickness. Coming to the demographic data, 29 eyes of 21 patients were included, of which 11 cases belonged to the second decade and 10 cases belonged to the third decade, youngest being 12-year-old and the oldest being 30 years, with mean age of 19.8 plus or minus 4.9 years, and 33% were females and 67% were males. 13 patients underwent cross-linking unilaterally, and 8 patients underwent bilateral cross-linking consequentially. There were no systemic associations in any of the patients, and 2 patients gave history of vernal keratoconjunctivitis, and cross-linking was performed at the quiescent stage of the disease, and there were no family history. And standard Dresden protocol was followed in all the cases where epithelium, after epithelial removal, riboflavin drops were put for 30 minutes, followed by UVA irradiation for 30 minutes, and BCL application, and post-operative standard protocol of topical steroids, lubricants, and antibiotics was followed. Coming to the ocular parameters, preoperative mean logMAR BCVA was 0.35. At final visit 5-year, it was 0.19 with significant p-value. So this shows that the logMAR BCVA has improved from the preoperative level, and it has also remained stable throughout the 5 years. And mean K max was 55.33 diopters preoperatively, and at final visit it was 53.01 with a significant p-value. It shows that K max has regressed significantly, and it has remained stable throughout the 5 years. Topographical astigmatism preoperatively was 5.45, that is mean topographical astigmatism, and at 5 years the mean topographical astigmatism was 5.11. Though it is not statistically significant, we can see that there is reduction in the topographical astigmatism, and it has remained stable throughout the 5 years. and mean spherical equivalent was minus 5.8 diopters. At 5 years, it was minus 3.04, which shows statistically significant regression and also remains stable. And central corneal thickness of 425, which reduced to 356, which has significantly reduced. So coming to the discussion, we have seen similar results has been reported in various studies in the literature. Quinones et al. Attained statistically significant improvement in corneal curvature and BCVA at 2 years postoperatively, and it has remained stable at 5 years follow-up. However, he had only minimum follow-up of 2 years, and Mazzotta et al. Showed documented progression in 10 patients, showed significant Kmax progression between 7th and 10th year follow-up visits. So this is the table showing different studies. Hashimi et al. Studied 40 patients for a duration of 60 months. He also showed significant improvement in BCVA. However, there was no significant improvement in Kmax spherical equivalent or the topographical astigmatism. And Mazzotta et al. Studied for the longest duration of 120 months, that is 10 years. He studied 62 patients. He also said BCVA has significantly improved. However, there's Kmax, mean spherical equivalent, and astigmatism, though it is reduced, it is not significant. And he also said 15% of patients showed progression. And Padmanabhan et al., it's an Indian study which also showed improvement in BCVA, Kmax, and astigmatism. However, there's no improvement in mean spherical equivalent, with 24% of patients showing progression at the end of 4 years. So coming to the conclusion, our present study shows the effect of collagen cross-linking in progressive keratoconus among the Indian population, with the highest mean follow-up duration of a minimum of 5.5 years and maximum follow-up of up to 10.2 years. So cross-linking has improved the visual acuity with significant reduction in the spherical equivalent and corneal curvature in progressive keratoconus patients, halting the disease progression. Thank you, and these are my references.
Doctor, were there any progression in your study?
Sir, there was one patient which showed progression after the 3rd year of postoperative duration, which, however, we followed them up for up to 5 years. However, the patient did not show further progression. His preoperative Kmax was 56.8, and at 3 years, it was at the end of 1 year, it was 54.9. However, at 3 years, 55.3 was the progression. From 54.9 to 55.3, it has increased. It remained stable till 5 years. So there is no significant progression as such. And none of the patients required any keratoplasty.
Okay. No, what I meant was, did that patient require repeat C3R?
No, sir. There was no. That patient did not require C3R, as that Kmax remained stable up to 5 years, sir.
Okay. Did your study look into visual rehabilitation also?
Yes, sir. Visual acuity. Most of the patients. Most of the patients went for RGP lenses, sir, and almost half the patients improved with the spectacle correction itself, and remaining of the patients improved visual acuity with RGP lenses, sir.
Yeah, if half of your patients were successfully managed by spectacle, that means most of them were mild to moderate cases.
Yes, sir. But however, the mean corneal thickness was 425, sir.
Yeah, that means slightly on the advanced side.
Advanced.
They wouldn't be happy with the spectacles. They would require some amount of rehabilitation with rigid contact lenses.
So since most of my age group patients were on their 2nd decade, so we could not teach them to learn how to use lenses. So most of the patients, we had to give them glasses for the visual rehabilitation. So over 18 years, we started giving them contact lenses, sir.
Okay. Okay. Fine. Thank you. So
Thank you, sir.
next speaker, please.
Yes.
Niranjan, Dr. Niranjan, are you ready? Dr.
Hello,
Niranjan?
sir.
Yeah, are you ready?
Yeah, I am not able to upload my PPT to the phone, and I'm not getting permission in the computer.
Okay, till you resolve your issue, I think we'll move to next speaker. Okay. Yeah. Next speaker. Who is the next speaker?
Hello, sir.
Yeah.
Hello.
Dr. Niranjan, you resolve your issue and then we'll come back to you. Don't worry.
Hello, sir.
Yeah. Dr. Raksha, present.
Sir, can you see my screen?
Yes.
Not moving.
Present.
Okay. Sir, good morning. Can you see my screen, sir?
Yes.
Yeah. Good morning. Yeah. My title of my study is Comparative Study of Corneal Endothelial Microscopy. There's no financial interest. Endothelium is extremely thin innermost layer of cornea. It is made up of single layers of densely packed flattened cell facing the anterior chambers. Many factors can affect the morphology of corneal endothelial cells, including age, contact lens wear, diabetes mellitus, ocular surgery, race, etc. Contact lens induces diurnal variation in corneal endothelium, which consists of intercellular stippling, separation of cell boundaries, and small blister-like areas separating the cells. Pathogenesis of endothelial changes in these contact lens wearers remains unknown. It is unclear whether the corneal endothelial polymegathism and pleomorphisms are caused either by relative long-term hypoxia, an anaerobic metabolic shift of the corneal endothelium, which will lead to buildup of toxic byproducts such as lactic acid, or due to chronic corneal swelling and deswelling. However, most likely etiological factor is chronic hypoxia. Also, in hard contact lens wearers, endothelium is more dependent upon aqueous oxygen than the stromal oxygen transmission from the epithelial surface. Numerous investigators have demonstrated the morphological changes in the corneal endothelial cells of the wearers of many types of contact lenses, that is hard, soft, and extended wear soft lenses. Such changes may be indicative of cell stress due to chronic hypoxia, which leads to lactic accumulation, elevated carbon dioxide level, and pH changes. Now, polymorphism may be a sensitive indicator of the health of the corneal endothelium, while polymegathism may be an indicator of altered cell function. Hence, the functional capacity of corneal endothelium may be correlated to its morphological appearance. The objective of my study was to find the influence of usage of soft contact lenses on the corneal endothelial cell count, as well as to observe the influence of soft contact lenses on corneal central thickness, coefficient of variation, and percentage of hexagonality. It was a hospital-based observational study conducted on medical students and doctors using soft contact lenses for myopic correction in MIMS Mandya. 50 participants were chosen, out of which 25 were cases and 25 were control. It was a study of duration of about 3 months, and the subjects were classified into following groups. Group A had subjects with usage of contact lens for less than 1 year, and Group B had subject using contact lens for more than 1 year, and Group C were taken as control, where they use spectacles for myopic correction. Data from each subjects were collected using a structured questionnaires of 12 items that included demographic profile, pattern of contact lens use, symptoms, brand name, number of years worn, and hours of daily wear. Non-contact specular microscopy was used to study the corneal endothelium, and corneal descriptors like endothelial cell density, coefficient of variation, percentage of hexagonality, and central corneal thickness were obtained. Inclusion criteria of my study had medical students and doctors using soft contact lenses for myopic correction, and myopia ranging between -1 diopter to 5 diopters were taken for the study, and age between 19 to 30 were selected as subjects. Whereas exclusion criteria had patients of any ocular history like ocular trauma, glaucoma, uveitis, and any eyes with anterior segment surgeries were excluded from the study. Patients who suffered from attacks of overwear syndrome were excluded from the study, and patients who didn't consent for the study. A slit lamp examination was performed on the cornea and anterior segment, and subjects were excluded if any abnormalities were noted. Results, the number of subjects with contact lens usage of less than 1 year were 16, and 9 of them with more than 1 year, and control were 25. It was observed that the central corneal thickness increased variably when compared to the controls, which was 524.2 in spectacle users, while in less than 1 year duration was 536.8 and 548.63 in more than 1 year. The endothelial cell density seemed to have reduced compared to the control, while it was 2,994.32 in controls, and less than 1 year had 2,652.76 and 2,558.98 in more than 1 year usage. The coefficient of variation has increased compared to the controls, while it was 0.36 in controls and 0.38 and 0.41 in less than and more than 1 year respectively. Percentage of hexagonality has reduced compared to the controls, while it was 52.83 in controls and 46.72 and 42.53 in less than 1 year and more than 1 year usage of soft contact lenses. These are the graphical representations of the same. This is central corneal thickness, which has which has increased. Endothelial cell density has reduced. Coefficient of variation has increased, and percentage of hexagonality has reduced. Discussion in this study, we found that the subject using contact lenses showed a statistically significant reduction in the mean corneal endothelial cell densities compared to the corneas in the control group, that is spectacle usage. The coefficient of variation of corneal endothelial cell was found to be significantly increased in subject using contact lenses. This increase indicated the presence of polymegathism, in which the endothelial cells enlarged to fill the gap between the adjacent cell. Study demonstrated significant difference in the percentage of hexagonal cells between the subjects using contact lenses and the control. Regarding the central corneal thickness in our study, there was significant difference between the subjects using contact lens and the control group. As regards the comparison of mean values of CCT, ECD, CV, and cell hexagonality in subjects using contact lenses for less than 1 year duration showed minimum variability compared to the controls, and those using contact lenses for a duration of more than 1 year showed moderate variability. Conclusion, daily wear soft contact lenses cause morphological changes in the corneal endothelium. With an increase in span of contact lens wear, there was significant increase in variation in the cell size, decrease in hexagonal cell percentage. Contact lens wear also caused increased central corneal thickness, and cornea became thicker with increased duration of contact lens wear. There was significant correlation between the duration of soft contact lens use and morphological changes of corneal endothelium. The proportion of hexagonal cells and mean corneal endothelial cell density in those using soft contact lenses for more than 1 year was significantly lower in the control group. Soft contact lens wear was significantly correlated with the decreased corneal endothelial cell densities with time. These are my references.
Which were the other studies which showed similar results?
Ma'am, these are the references taken from the study.
Can you please go to the title slide once?
Yes, can we move on to the next speaker?
Hello, this is Niranjan. Can I do my PPT now?
Yes, Niranjan, you can share your screen.
Thank you. Someone else is still.
Yeah, Dr. Raksha, can you stop your screen sharing? Yes, Niranjan, you can go.
Shall I?
Yeah. You.
Thank you. Good morning, everyone. I'm going to present about a study of contralateral eyes in patients who underwent collagen cross-linking in one eye for keratoconus. So, introduction: keratoconus is an asymmetric, bilateral, progressive, and non-inflammatory ectasia to gradual and mechanical instability of cornea. Its reported frequency is approximately 1 in 2000 in the general population. The condition usually begins at puberty and progresses in approximately 20% of patients. Corneal collagen cross-linking with riboflavin and ultraviolet A is a technique of corneal tissue strengthening using riboflavin as a photosensitizer and UVA rays to increase the formation of intra and interfibrillary covalent bonds by photosensitized oxidation. The aim of this study was to study the contralateral eyes in Patients who underwent cross-linking with riboflavin solution and ultraviolet light for 1 eye for keratoconus. The materials and methods. A retrospective study was conducted in a hospital of 45 patients who underwent collagen cross-linking with riboflavin solution for 1 eye with progressive keratoconus. The medical records of the patient were collected from medical records department of our institute, and patient's demographic data, visual acuity, and straight line biomicroscopy findings were collected from the same. Patient's corneal topographic findings before the procedure were collected from the data saved in Oculus Pentagon. These data were compiled in Microsoft Excel and statistical evaluation was done. So the results, a total of 45 patients' medical records who underwent collagen cross-linking with riboflavin solution for 1 eye with progressive keratoconus was collected. Out of 45 patients, 23 were male and 22 were female with an average of 18.48 years, ranging from 11 to 31 years. 18 patients underwent procedure for the right eye, while 27 patients for the left eye based on their clinical and corneal topographic findings. Out of these 45 patients, 23 patients had history of Werner keratoconjunctivitis, and the number of eyes with clinical features of keratoconjunctivitis are mentioned in a table. Around 13% had Vogts-Dry in the operated eye, and around 15% in the contralateral eye. While Friction Singh also around 13% in the operated eye and around 8% in the contralateral eye. These were the one of the patients, Vogts-Dry and Friction Ring. The thinnest spectrometry in contralateral eyes was 441.53 micron meter with a standard deviation of 42.41 micrometer, which indicates thinning in the non-operated eyes too, compared to the 432.02 micrometer in the operated eyes. Other corneal topographic findings are mentioned in the table as below. So we can see that even in the non-operated eye, there is findings of keratoconus and thinning. Going to the discussion, keratoconus is a bilateral progressive ectasia of cornea. If untreated, keratoconus progresses, which has been documented by various studies. If we treat the earliest stage of the disease, a better visual acuity might be preserved. Therefore, as patients present with keratoconus in 1 eye and it is a bilateral condition, evaluating the contralateral eye will help in early intervention, preserving better visual acuity. These are my references. Shall I stop sharing?
Yes, Niranjan. We'll move to next speaker.
Thank you.
My title is Corneal Endothelial Changes in Type 2 Diabetes Mellitus Patients Using Non-Contact Specular Microscopy in Tertiary Care Center. No financial interest. Introduction. The corneal endothelium is a single layer of cell that plays a major role in maintaining the optical transparency of cornea through the sodium-potassium ATPase pump activity. The corneal endothelial cells have the highest density at birth, which decreases by approximately 0.5% per year following aging. A reduced corneal endothelial cell density and swelling of the cornea are the indicators of corneal dysfunction. Then diabetic retinopathy remains the most commonly studied manifestation in eye. However, the functional abnormalities have been documented in cornea too, like a decreased endothelial cell density, increased corneal thickness. Corneal endothelial cell is responsible for maintaining the transparency of cornea. There is limited ability of mitosis in corneal endothelium, and once damaged, remaining cells enlarge to cover up the lost area. There will be an increase in variation of cell area called polymegathism or coefficient of variation, and index of hexagonality or pleomorphism. Central corneal thickness can be used as a marker of endothelial health and can be used to monitor the corneal edema. Objective is to observe the differences in corneal endothelial cell morphology and corneal thickness in patients with and without type 2 diabetes related to disease duration and HbA1c percentage. Materials and methods. Study design is hospital-based case control study. Study area is outpatient department of ophthalmology. Sample size is 100 participants, 50 cases and 50 controls. Study period was from March 2021 to August 2021. Study subjects were cases of 50 diabetes patients with poor glycemic control, and controls were 50 non-diabetic patients. 50 diabetes patients are divided into 4 groups based on duration, 2 groups, that is less than or equal to 10 years and more than 10 years, and 2 groups based on HbA1c levels, that is less than or equal to 7.5% and more than 7.5%. Most of the patients with HbA1c level less than 7.5% belong to duration of less than 10 years, and more than 7.5% belong to more than 10 years duration. Cases and controls were defined as patients of type 2 diabetes mellitus and age-matched non-diabetic individuals, respectively, attending the outpatient department of ophthalmology. The demographic data such as age, gender, and relevant diabetic history was noted, and the non-contact specular microscopy was used to study the corneal endothelium. The corneal descriptors like endothelial cell density, coefficient of variation, and percentage of hexagonality and central corneal thickness were obtained. Inclusion criteria: all the patients having type 2 diabetes mellitus above the age of 40 years, and exclusion criteria included a positive history of corneal diseases, long-term use of contact lenses, glaucoma or previous anterior segment surgeries, uveitis and laser treatment, and patients of type 1 diabetes mellitus. Results: out of 50 diabetic patients, 24 belong to the duration of less than 10 years, and 26 belong to more than 10 years duration, among which 20 belong to less than 7.5 HbA1c level, and 30 belong to more than 7.5% of HbA1c. 4 out of 24 patients with duration less than 10 years belong to HbA1c percentage of more than 7.5 category. Among the diabetic patient and group with HbA1c less than 7.5%, the approximate central corneal thickness was 544, and endothelial cell density was 2537, CV was 0.39, and hexagonality was 39.58. And among the patients with HbA1c more than 7.5, CCT was 556, and endothelial cell density was 2458, and CV was 0.43, and hexagonality was 35.54. And among duration less than 10 years, CCT was 542, and endothelial cell density was 2509, and CV was 0.40, and hexagonality was 38.61. And among duration more than 10 years, CCT was 550, and endothelial cell density was 2477, and CV was 0.42, and hexagonality was 33.26. And among the controls, CCT was 539, endothelial cell density was 2629, CV was 0.37, and hexagonality was 48.24. This is a bar graph showing the central corneal thickness increased in HbA1c more than 7.5% and duration more than 10 years. Endothelial cell density reduced in HbA1c more than 7.5 and duration more than 10 years. CV showing raise in HbA1c more than 7.5 and duration more than 10 years. And hexagonality is reduced in diabetes compared to controls. Discussion: in this study, we have found that the diabetic cornea showed a statistically significant reduction in mean corneal endothelial cell density compared to the corneas in the control group. Also shows significant increases of CV in diabetic patient, and study also demonstrated significant difference in percentage of hexagonal cells between the diabetic and the controls. CCT showed a significant difference in diabetic and non-diabetic patients, and the comparison of mean values of all the indices in the patients with diabetes mellitus duration of less than 10 years shows minimum variability compared to controls, and those with duration more than 10 years shows moderate variability. And the comparison of mean values of all the indices in the diabetic patients with HbA1c less than 7.5% shows minimum variability compared to controls, and those with HbA1c more than 7.5% shows moderate variability. Conclusion: this study documented that type 2 diabetes resulted in significant reduction of endothelial cell density and increased CV. Also, the diabetic cornea had increased central corneal thickness and lower percentage of hexagonal cells than in the cornea of the normal subject. Our study demonstrated that diabetes mellitus duration and HbA1c levels had a significant correlation with the central corneal thickness, coefficient of variation, hexagonality, and endothelial cell density. These are my references.
Thank you, doctor. Shall we move on to next speaker?
Thank you, sir.
Who is the next speaker?
So actually Meera is the next presenter, sir. Next to her is mine, Aparna here.
Yeah, present. Please present. Dr.
Okay. I'm presenting you an observational study of demographic and geographic patterns in corneal ulcer patients attaining tertiary care hospital. Coming to introduction, according to World Health Organization reports, corneal ulcers are the leading cause of corneal blindness in developing countries. Corneal ulceration results in 1.5 to 2 million new cases of corneal blindness annually, posing a major health problem. Out of all the suppurative causes of corneal ulcers, the most common etiological agent is fungal, following which is the bacteria. This varies by geographical area. These pathogens lead to corneal damage directly or by release of toxins and enzymes by inactivating the host immune mechanism. An intact corneal epithelium acts as a barrier for the majority of microbial agents. These agents can penetrate through a breach in the epithelium followed by ocular trauma. Various risk factors have been implicated for increased incidence of corneal ulcers, including widespread use of antibiotics, steroids, and use of contact lens and postoperative infections, more importantly, ocular trauma. Aim of the study was to determine the predisposing risk factors based on demographic patterns and geographic patterns. Materials and methods. This was an observational cross-sectional study with a study subject of 100. Selection of subjects, both male and female belonging to different socioeconomic age groups were selected. Inclusion criteria, all clinically diagnosed corneal ulcer patients are included in the study with exclusion criteria of cases presenting as non-infectious keratitis such as peripheral ulcerative keratitis due to systemic autoimmune diseases, Moran's ulcer, flictenular keratitis, vernal keratoconjunctivitis associated shield ulcer, etc. The demographic profile, clinical feature, and clinical course of illness were recorded. A questionnaire-based interview was done as per performer. Detailed clinical history, prior medications, precipitating factors, etc. were noted for every case. These were the observations made. The age distribution and gender distribution. In this, out of 100 patients, most of the patients belong between the 30 to 50 years of age, and the youngest patient in the study was 22-year-old and the oldest was 68-year-old. And out of 100, there were 78 males and 22 females. Coming to the occupational distribution, 60 out of 100, 68 were agricultural workers and 32 were industrial workers, and housewives 2, and others were 14 in number. Geographic distribution showed rural population was 72 in number and urban 28 in number. Predisposing factors like ocular trauma was associated with 68 cases, exposure keratitis in 12, ocular surface disease in 8, dicrocystite in 6 cases, eyelid or lash abnormality in 6 cases. And the association with systemic illness was also noted. Diabetes mellitus was the frequently seen association in 48 cases, HIV in 10 cases, hepatitis in 4 cases, and no association was seen in 38 cases. Conclusion, out of 100 cases in this study, majority of these cases belong to 31 to 50 years of age group. The period exposed to more stress and trauma. Male to female ratio was 3.5:1, denoting males were affected than females, probably because of more in outdoor activity and more chances of exposure to the contacts. Majority of patients were from rural community. Most of the patients were either agricultural laborers or other manual workers. Ocular trauma is the most common risk factor. Among them, vegetative matter is responsible for 33 cases. The comorbidities association was diabetes mellitus in 48 cases, followed by HIV and hepatitis. No systemic association was seen in 38 cases. Discussion. Corneal ulceration has been recognized as a silent epidemic in developing countries. It's an avoidable vision-threatening disease that still represents a considerable proportion of the daily new cases that creates a huge burden on the resources of health services. Therefore, the present study is an attempt to analyze the demographic and geographic patterns in corneal ulcer patients. Similar results were observed in the reference studies that I have mentioned here. Thank you. Hello.
Thank you. Thank you. We can move to next speaker.
Yes, sir. Thank you, ma'am.
Speaker, who is the next speaker?
Hello,
Yes.
this is Dr. Anupama. Can I present, sir?
Yeah, you can present.
Good morning. I'll be talking on a study depicting trend in the acquisition, storage, utilization of the corneal tissue in pre and during COVID era. Introduction. After cataract and glaucoma, corneal blindness takes the third leading position for the cause of blindness in the world. In India, it is estimated that there are approximately 6.8 million people who have vision less than 660 in at least one eye due to corneal disease. And out of these, about 1 million have bilateral involvement. It is estimated that approximately 20,000 patients with corneal blindness are added to the backlog each year, and that 50% of corneal blindness is treatable. Many of these corneal blind patients may be visually rehabilitated by corneal transplantation.
Video of presently.
And efficient and precise utilization of the donor corneas in developing countries like India is only possible after a complete knowledge of the collection, storage, and utilization of donor tissue. Thus, this study was conducted with the objective of identifying the trends in collection, storage, and utilization of the corneal tissues at an eye bank during pre-COVID and during COVID era. Objective is to evaluate the corneal tissue acquisition, storage, utilization trend in pre-COVID versus during COVID. Methodology. This study was performed at a tertiary care hospital linked to an eye bank. The data was collected retrospectively from January 2015 till August 2021. Details including donor demographical profile like age, sex, cause of death, serology, source of tissue, hospital or home enucleation, tissue preservation, recipient data like demography, age, sex, diagnosis, type of procedure performed, done, were collected and analyzed. Results. The total number of eyes that were procured in the 7-year study period was 1,313. In the year 2015, a total of 232 eyes were procured. 2016, 189 eyes were procured. 2017, 214 eyes were procured. 2018, 296 eyes were procured. 2019, 237. Whereas during COVID 2020 and 2021, only 50 and 90 eyes were procured respectively. Death to preservation time, a total of 436, 33.20% of tissues were procured within first 2 hours of death. 2 to 4 hours, 474 tissues were procured, 36.1%. 4 to 6 hours, 378 tissues to 28.78%, and more than 6 hours, only 25 tissues were procured, 1.90%. Storage media used. Most commonly used storage media was MK media, 52%, followed by moist chamber, followed by cortisol. Tissue utilization. Out of the 1,313 tissues, 749 tissues were utilized, 57.04%, out of which 312 tissues were used for therapeutic penetrating keratoplasty, 248 tissues were used for optical penetrating keratoplasty, and 189 tissues were utilized for lamellar keratoplasty. Indication for surgery. The most common indication was non-healing keratitis, infective cause, perforated or impending perforation, followed by anterior staphyloma, followed by pseudophakic bullous keratopathy, followed by adherent glaucoma, and then advanced keratoconus. During the year 2020 and 2021, only a total of 145 tissue, 11.04% were procured, out of which in the past 7 years, out of these 145 tissues, 100 tissues were utilized mostly for therapeutic penetrating keratoplasty, followed by OPK and lamellar KP. 45 tissues were used for research purpose or practice surgery. There was no change in the storage of the tissue was noted. In spite of low tissue procurement, tissue utilization was done adequately, keeping the COVID-related safety measures in mind. Discussion. The COVID-19 pandemic has brought with it a huge burden of mortality and morbidity across the world, and the added effects of the mandatory lockdown measures to try and control the spread. Prioritize surgeries as per the level of medical urgency for corneal transplants. Tectonic and therapeutic corneal transplants to be done on priority over optical and lamellar corneal transplant. Special consents can be added to the pre-operative protocol for COVID-19 time. There are a number of other procedures and surgeries which may be required on emergency and semi-urgent basis and can be prioritized and undertaken with the necessary care and precautions. And awareness amongst the people is also of utmost importance for pledging their eyes. Conclusion, there is significant reduction in the amount of tissue acquisition of the during the COVID era in comparison to the pre-COVID era, attributing to the risk factors associated with the COVID-19 pandemic. But the tissue utilization of the acquired tissue is adequate. However, with the better PPE equipment, staff training, COVID-19 RT-PCR testing, and proper protection, one can encourage and create awareness amongst the general population to donate and pledge their eyes. These are my references.
Thank you, Kinjal. We'll move to next speaker.
Hello.
Yes, Dr. Anupama.
Can I present, ma'am, now?
Yes, Anupama.
Yes.
Yeah,
Is
please
my
start your
screen
presentation.
visible now?
Yes,
Yes,
yes.
It's a study on demographic and clinical profile of patients who underwent therapeutic keratoplasty tertiary care center. Introduction. The therapeutic keratoplasty facilitates the removal of infected corneal tissues in eyes unresponsive to antimicrobial therapy. The indications for the therapeutic keratoplasty can be varied in number. The corneal graft is immunologically privileged with an absence of blood vessels and lymphatics and the presence of relatively few antigen-presenting cells. Inflammation and neovascularization contribute to loss of this privilege and in turn resulting in graft failure and graft reinfection. The demographic and clinical profile of the patients play an important role in corneal graft rejection as well as the graft failure and reinfection. Aim of the present study is to assess the demographic and clinical profile in patients who underwent keratoplasty in our tertiary care center. The materials and methods used for the study are as follows. A retrospective study was conducted of 42 patients who underwent therapeutic keratoplasty for varied etiologies in Minto Ophthalmic Hospital. The patient's demographic data, etiology of therapeutic keratoplasty, the type of therapeutic keratoplasty, size of donor and host cornea, number of reprocedures, indication for reprocedures, duration between primary and reprocedures, and data on additional procedures underwent by patients were collected. The data compiled in Microsoft Excel software and statistical evaluations done. The results were as follows. A total of 42 patients' medical records who underwent therapeutic keratoplasty were evaluated. Out of the 42 patients, the 30 were males and 12 were females. The majority were males, amounting up to 71.4%, with average age being 53 plus or minus 14 years. The type of keratoplasty done was therapeutic penetrating keratoplasty in 32 patients, the tectonic penetrating keratoplasty in 9 patients, and therapeutic lamellar keratoplasty in 1 patient. The indications the indications were the topmost was a non-healing fungal corneal ulcer, which was seen in 25 patients, which amounted up to 59.5%, and bacterial keratitis in 4, regraft in 7, anterior cephaloma in 2, fungal corneal ulcer with anterior cephaloma in 1 patient, and desmotos in 1 patient. Overall, average size of the donor cornea defined was 9.8 plus or minus 0.8 mm, ranging between 8 mm to 11 mm, and recipient cornea was 9.2 plus or minus 0.8 mm, ranging between 7.5 mm to 10.5 mm. Average size of the donor cornea defined was 10.58 plus or minus 0.49 mm, and recipient cornea the 10.08 plus or minus 0.49 mm in patients who underwent the retherapeutic keratoplasty. Retherapeutic keratoplasty was done in 7 patients, which was 67% of the total lot, and indication were for the same way graft reinfection in 4 patients, that is 9.52% among these, and failed graft in 3, that is 7.14% patients. The average duration between primary and regraft was 1 month. These are the pre-op photo of a patient with fungal corneal ulcer and the post-op the picture for following therapeutic penetrating keratoplasty. The conclusion, the fungal corneal ulcer still remains the most common indication for therapeutic keratoplasty as depicted by my study, and also for regrafting due to its resistance to medical line of management. My study also showed that as larger infiltrate prior to therapeutic keratoplasty had much higher risk of recurrences, the timely surgical intervention should be considered in cases not responding to medical therapy. Alternative strategies of management of post-operative inflammation need to be considered in order to prevent the graft failure or graft reinfection. The references were as follows. This study have no financial disclosure or conflicts of interest with the presented material in the presentation. Thank you, ma'am.
Thank you, Anu. Do we have any next speaker?
Ma'am, can I present now, ma'am?
Yes, Anupama. Karthik, sir, can you handle this?
Are you presenting right now?
Sir, yes, sir, I can share now, sir.
Okay, then start.
Sir. Yes, sir, I can present now, sir.
Yeah, present.
Can you see, sir?
Yeah, I can see.
Okay, sir. Good morning, everyone. Today I am going to present a paper on limbal relaxing incisions during cataract surgery to correct corneal astigmatism. Coming to introduction, approximately 70% of the general population has at least one diopter of astigmatism, and approximately 33% of patients undergoing cataract surgery are eligible for treatment of pre-existing astigmatism. Among astigmatic corrective surgical procedures such as astigmatic keratotomy, limbal relaxing incisions, LASIK, and toric IOL implantation, limbal relaxing incision is known to be useful, cost-effective, convenient procedure for reducing pre-existing corneal astigmatism. Coming to material and methods, this is a prospective comparative hospital-based interventional study conducted from November 2019 to June 2021. 70 patients undergoing cataract surgery with pre-existing astigmatism were divided into two groups. First groups contained 35 cases and second 35 controls. Cases underwent manual small incision cataract surgery with PCIOL implantation with limbal relaxing incision, and control underwent manual small incision cataract surgery with PCIOL implantation alone. All surgical surgeries were performed by a single surgeon under peribulbar local anesthesia. In both the groups, manual small incision cataract surgery with PCIOL implantation was done using superior crown-shaped incision, which was around 1 to 1.5 mm away from the superior limbus. In cases group, the limbal relaxing incision was performed after PCIOL implantation before viscoelastic wash. A Mendez ring was used to mark the incision. Based on the nomogram found by Dr. Donenfeld, the incision were placed at the outermost periphery of the clear cornea using a 600 micron depth guarded disposable blade. Inclusion criteria: all patients who presented to the Department of Ophthalmology with senile cataract with KH more than KV of more than one diopter astigmatism during the study period were included in the study. Exclusion criteria: patients with corneal pathologies, glaucoma, dry eye were excluded, and patients with retinal pathology were excluded from the study. Pre-operative evaluation: a detailed history, external examination of both the eyes, visual acuity recording and refraction, slit lamp examination was done, fundus evaluation was done, IOP measurement and gonioscopy in relevant cases were done. Lacrimal sac syringing, ultrasound biomicroscopy, and IOL power calculation using SRK-T formula was done. Post-operative evaluation was done on day 1, day 7th, 1 month, and 6 months of surgery. At each post-operative visit, distant vision, near vision, refraction, keratometric reading were recorded. Coming to results analysis, they were divided into 40 to 50 years, 51 to 60, 61 to 70, and more than 70. In cases and control, there is no significant difference present in the age distribution in both the groups. Coming to gender distribution, in cases and controls, there is no gender differences are present in both the groups as p-value is 0.62. Coming to mean preoperative corneal astigmatism, it is 1.59 diopter in cases, 1.56 diopter in controls group. There is no significant difference present in both the groups as p-value is 0.65. Coming to post-operative astigmatism between the cases and the controls. In cases, at day 1, it is 0.68 diopter, at day 7, 0.67, at 1 month, 0.9, at 6 months, it's 0.12. In controls, at day 1, it is 2.17, day 7, it is 2.25 diopters, at 1 month, it is 2.34 diopters, and at 6 months, it is 2.32. There is a significant difference present in the mean post-operative astigmatism between the cases and the controls as the p-value is 0.001. Coming to post-operative uncorrected distant vision at 1 month, there is also significant difference present between the cases and control as the p-value is less than 0.001. There are more cases in the LRI group in the 6x6, 6x9 visual group, whereas there are more cases in control group in between 612 and 618. Coming to post-operative uncorrected distant vision at 6 months, here also there is significant difference present between the cases and controls, as the vision is good in the cases group control compared to the control groups. Coming to discussion, when I compare my results with the other studies, in our study, the mean preoperative astigmatism is 1.59 diopters, post-operative 1.2. The mean astigmatic reduction is 0.39 diopters. In Sharma et al. Study, the mean pre-op astigmatism is 2.08, mean post-op is 1.05. In study conducted by other studies also, there is significant reduction in the mean preoperative astigmatism. Coming to conclusion, the limbal relaxing incisions performed during cataract surgery is an effective and stable procedure to reduce preoperative astigmatic corneal astigmatism. Thank you.
Yeah. Thank you, doctor.
Thank you, sir.
That's